Welcome to Eyes Wide Open channel. It's me, Sasha, and today I'm going to talk to Dr. Alex Quaas. Since 1978, there are about 8 million babies are born with IVF. And today, my question to Dr. Quaas will be, how far did science go and how far can we choose the gender, maybe eye color or maybe something else?
My doctor, Dr. Quaas, he is amazing. Quaas, yeah. Okay. He is the best, and he listens, actually, and he loves us all talking about it. But yeah, he's amazing, really funny, and he just like makes this really easy to understand. They're all at Reproductive Partners Fertility Center, and he is so hot.
I looked up all our messages in our group chat and remember the audio file you sent from the reporter.
Oh yeah, that was funny.
How did you feel about that?
The
did you
radio.
Feel yes?
I thought, I felt flattered. I thought it was good. Good publicity.
It's a really
nice
feedback, right?
Yeah, she was nice. She was always talking about her treatment on the show, and one time, one of the other show hosts gave her an injection as part of the treatment on air. And then, but it was great because she raised awareness of IVF and infertility, and I always thanked her for that. But at the same time, it was a bit hard because, in infertility treatment, it's like a roller coaster. Sometimes things go well, and sometimes things don't go so well. And if you share it, which is great because you get support and you raise awareness. Then sometimes, unfortunately, you also have to share the hard parts. And so that's like when people ask, when should I tell my family and my friends that I'm pregnant? And so I usually say, well, you can share it with your sort of closest friends and closest family, but if something happens and the likelihood of having a miscarriage, for example, is highest at the beginning, then you also have to share with them if that happens. And that's harder. So that's why most people wait until they're like 12 weeks or 14 weeks pregnant before they share the news of a pregnancy.
How many kids did you make?
Today or in general?
In general.
In general. So I don't think, I haven't really counted the number of babies that have been successfully a result of fertility treatment that I've done. But in our clinic, we do about 600 cycles per year, and more than half of them are successful. So, over time, it must be definitely over 1,000.
So you definitely don't keep a track on their names?
Well, not every single one, but I do keep in touch with some of the patients that have had a baby through treatment. So, for example, I spent 4 years at the University of Oklahoma, and some of the patients from the time, some of whom actually went to my wife for their obstetric care, they've kept in touch through social media.
Nice. How did you decide to choose this
field?
Field?
That's a very long story, but just to sort of keep it short. When in medical school, I first wanted to become a cardiologist, but then I realized that one of the reasons I wanted to do that is because I like to do stuff with my hands. So then I did surgery, and I actually did orthopedic surgery for a year. In orthopedic surgery, I felt like there was not enough talking to the patient. And so then I'd always tried to avoid doing the same thing that my dad did. My dad was an OBGYN in Germany. And so finally I realized that maybe, we're similar personalities, and maybe the mixture of medicine and surgery that field has, which is wonderful, is also something that I would like. And so I'm really happy that I sort of followed in his footsteps. But he didn't do infertility treatment. That was sort of my little way of being individual, because I thought that has the biggest mix of science. It's like the fastest evolving field in obstetrics and gynecology, but at the same time, interesting clinical work. So it's evolving all the time, and on a day-to-day basis, I feel like I'm sort of having very exciting experiences, and patients are very grateful. They also follow our instructions, more than in any other field in medicine, because they're very motivated.
How many years did you study for that?
So I did medical school was like 6 years, and then I finished medical school in 2002, and I was basically quote unquote fully trained in 2013. So like 11 years after medical school.
And what do you do at work? Your daily routine?
So our daily routine is that in the morning we do a lot of ultrasounds and treatment monitoring for cycles. So basically the treatment cycles that we do, they include a lot of monitoring what happens in the ovaries of patients. So I look at a lot of ovaries in the morning. So those are usually quick visits, like 5 to 10 minutes, where we just monitor how the treatment is going. But then we also do procedures like taking out eggs from the ovaries. That's called egg retrievals. And then we do embryo transfers. So we put embryos into the uterus, but we also do inseminations, which is where we put a sperm sample into the uterus. So those are the classic things that we do throughout the morning. And then in the afternoon, I do consultations and more procedures.
Couples or women, they come to you.
Yep.
And how long does it take them before they start trying till they come to you?
Yeah, that's a good question. So basically, it's recommended that women under 35, when they're trying to get pregnant, that they try for about 12 months if they have regular cycles. If they have irregular periods, then maybe they should get that checked out sooner. But if they have regular cycles, about 12 months, they should try on their own and then maybe get a checkup. And the checkup usually includes things like checking the sperm on the husband's side, making sure the tubes are open on the female side, making sure the ovaries are working so they're ovulating normally and they have a good number of eggs left.
What's the first question you ask your patients?
How long have you been trying? And then the second, maybe how many babies do you want?
What are the most common reasons why couples cannot have kids?
Yeah, that's also an excellent question. So basically, when a couple comes to me, I usually first go over how a baby is made. And so during intercourse, the sperm swims through the uterus into the tubes. And in the tube, if the sperm is lucky, it meets an egg that has ovulated from the ovary and then been picked up by the tube. And the tube is a connection between the uterus and the ovary. And then the egg becomes a fertilized egg and then becomes an embryo. And that embryo slowly travels back as it develops into the uterus and then it implants. So I always tell patients that because based on that, you can easily understand what the causes are. They're basically in 4 groups: sperm, ovulation, anatomic factors like the tube and the uterus, and then ovarian reserve. And ovarian reserve is essentially how many eggs a woman has left, but also the quality of the eggs.
I spoke last week with a sexologist, and she mentioned that a good sex can help to conceive babies.
Been proven that it's easier to conceive a baby if you have orgasm, it's better blood flow, the uterus reacts better to, and the ovaries react better to semen, and so on and so forth.
Yeah, well, I mean, I see it more sort of scientifically. As long as the sperm gets into the system, then it can get to the egg. So I don't know that I know research that the quality of the sex impacts the pregnancy rate.
Thank you.
But yeah, so as far as I'm concerned, I just sort of make sure that there's enough sperm, that the woman ovulates, that the tubes are open, because if the tubes are not open, then the sperm and the egg are sort of like Romeo and Juliet on 2 different sides of a wall or something. They can't get together. It's tragic. But also, like, a very common reason nowadays in our society when couples wait longer and longer to get pregnant is that the eggs get older and older. And one thing I always stress is that a woman is born with all the eggs she's going to have. So men make new sperm all the time, but women are born with all the eggs they're going to have. And so over the course of their lifetime, the number of eggs and the quality of eggs goes down. And so as, our professional work lives, people are sort of more into their careers, which is a wonderful thing, but they also maybe wait longer and longer to have babies, and then that leads to problems because we have a lot of patients at the end of their 30s, early 40s, and they're trying to get pregnant, and then the egg quality or the egg number might be an issue.
I didn't have this question planned, but I will ask you, do contraception can lead to the...
No, I think that's a myth. I mean,
okay.
That's a commonly held myth that if you are on the pill for many years or something like that, that might impact your fertility, but it really doesn't. So actually being on the pill for a number of years is not a reason for infertility, and when people come off the pill, it might take a little moment for the cycles to become regular again and for ovulation to start up again. But in general, contraception is not really a reason for infertility.
When you make this procedure, and sometimes you have to make a decision which egg, right? Which egg you keep and which egg.
Yeah.
How do you make this decision? Based on what factors?
Yeah, so when we do IVF, so when we do treatments that don't involve taking out the eggs.
In vivo.
In vivo, exactly. Then basically things happen inside and then we don't have access to the eggs in the embryo. But when we do in vitro fertilization, then the process of the egg and the sperm coming together and the egg getting fertilized and the development of the embryo, that all happens in our lab. And so then usually, you know, in a couple, so in single women, we can freeze eggs and then we keep all the mature ones. But if it's a couple, then we grow the embryo to quite an advanced stage, actually 5 days after ovulation. It's called a blastocyst. And those ones, there's a grading system. So obviously the embryo has to still be, you know, alive and growing to be functional. But also the embryologist, so our lab expert, looks at it, grades it, and then the embryo can even be tested at that point. And then, so all the high quality ones will be kept and frozen and potentially tested.
If, let's say, 3 of them are really good ones, do you keep them all, or it's a decision for the couple to make?
No, I mean, usually we recommend keeping them all because the freezing technology is one of the biggest factors in our field, and that's one of the biggest advances over time, that we've become so good at freezing stuff. And so we freeze all the embryos, keep them for the future, and they're individually frozen. And this is actually an interesting and very important fact for people to know. If you do IVF, it helps people get pregnant immediately, but it also helps people preserve their fertility. Because if you freeze an embryo, let's say at age 32, you freeze an embryo, and then, but the couple is not ready to have a baby yet. If that woman comes back at age 40 and she uses an embryo that was frozen at age 32, then she has the chance of pregnancy and the risk of miscarriage of a 32-year-old, even though her body and her uterus is now 8 years older. And so freezing embryos is a good idea for people that want multiple children, that want children maybe not now, but later. And, you know, basically sometimes it works out that a couple can do one cycle, they can have one baby with the first embryo, and then have more embryos frozen for the future, so they don't have to go through that initial process of IVF again.
So the child will have its own sibling, the same age basically, genetically in the same order.
You know, since it's frozen, it doesn't really, you know, it's frozen in time. So, you know, I would still say, you know, they're not the same age in the end.
I'm telling you, I'm like, talk to me like I'm 5 years old. Right?
No, I mean, I think that's a good question. I mean, I think there was recently a report in the media that an embryo that was frozen 23 years ago resulted in a pregnancy. So that's quite crazy to think that that you know, baby has already like kind of existed for more than 2 decades.
Right. So this beginning of life was here already.
Yeah,
for a few
exactly.
Decades. Is it covered by the insurance usually? Or
Unfortunately, there are some insurances that cover it, but unfortunately most insurances don't. And it's estimated that in the United States only about 10% of couples that need treatment have access to it or are covered by insurance, something like that. There are a handful of states in the United States where there's a law that insurances have to cover infertility services. But unfortunately, California is not one of them, and there's only like a handful of them. And in those states, insurances have to cover it, and then there's certain like regulations as to how many cycles you can have and that kind of stuff. But in most places, people unfortunately have to pay out of pocket, and that's because there's still this perception in the public that this is sort of an elective thing, that this is something a bit like plastic surgery. Like if you want a facelift, you know, you should have to pay for it yourself. And so if you want a baby, you know, that some people put that on the same level. I don't, because I think infertility is a disease, and the World Health Organization has recently actually recognized infertility as a disease. And so that was a step in the right direction. Now the insurances just need to also recognize it as a disease and cover the treatment for it.
I see. You're from Germany. Is it different in Germany?
There are some differences in Germany. So I think that the regulations and laws are a little bit different. So there's some legal differences. For example, when a woman who is on the older side or who has very few eggs left wants to get pregnant, sometimes women do treatment with egg donation. So they essentially pick an egg donor, usually they're in their 20s, the egg donor who still have very healthy eggs, and they give their eggs, and then we make embryos and use that for the woman who might be 45 to have another baby. And so, for example, that is illegal in Germany and some other countries in Europe. So it's interesting because in Europe, it's a relatively small or not that huge continent, but there are many differences in the reproductive care from country to country. So, for example, when German women need egg donation, they often go to Spain or the Czech Republic, and that's called reproductive tourism. Or, for example, donor sperm in some countries is not easy to have. For example, I worked in Switzerland for a year, and they had a rule that you could only use donor sperm if you were a married couple and the husband did not have sperm. But for example, single women or lesbian women were not allowed to do that. So they went to Denmark, for example. In Denmark, Copenhagen, there's a few midwife practices that do inseminations, and so that's one option. But you have to travel. And so in the United States, the regulations are relatively liberal, and pretty much everything is allowed that we need to do. But there are always discussions, about these things. It's fascinating because there's this movement to try to pass personhood amendment to give the embryo the same protections as a human being. Mm-hmm. And while that sounds like a sort of generally good idea, it can create problems for the things that we do, and it can make it more difficult for infertility treatment to happen. I mean, for example, it's this gray area. Like, for example, is it okay to discard embryos? Like, is an embryo, like, is that almost like having an abortion? If you create an embryo and then you throw it away, is that? In my opinion, it's not, because the way we see it, and one of my big mentors in fellowship has actually written an editorial in the LA Times about that. An embryo is a cluster of cells that has the potential of life under the right circumstances, but it's not a life in the same way that a 3-year-old child is alive, in my and many other people's opinion. But of course, these are challenging ethical questions. So one of the things I love about the thing that I do is it's scientifically very interesting. There are also many ethical questions that are very interesting.
Yeah, that was my next question about the ethical code you have in your profession. It's also probably differs from country to country.
Definitely. Like, for example, let's say somebody a couple has 3 boys and they want a girl. Should they be allowed to do IVF with the only purpose of having a girl? Those are interesting and challenging questions. Or, for example, like there was this discussion, regarding, for example, congenital deafness, and a couple, they both like have a congenital mutation that they're deaf, and they want a deaf child. Is it okay because they want the child to be in the same community? These are interesting questions. Or another one that I've always been fascinated by is there is a disease that's called Huntington's disease or Huntington's chorea that only starts after the age of 50. And so if you have a parent who has it, you have a 50% chance of having it yourself. And so sometimes a patient with that might say, I don't want to know if I have it, but I don't want my baby to have it. And so they do IVF, and they tell the doctor, don't tell me what my status is, but give me a baby that doesn't have it. And so halfway through this process, the doctor might find out that they don't have it and that the IVF treatment is unnecessary, but they sign something beforehand that they're still going to go through, because unless you're consistent with that, this wouldn't make sense. So there are these ethical dilemmas that come up, and this is a rare one, but there are many on a daily basis. There are things that are more common regarding
for example,
this.
gender.
Exactly.
Or eye color, Or
Yeah.
so where is this fine line where the nature steps away and science takes over?
Yeah, so I think most sort of practices still do this in a way where the medical necessity and the medical indication is the number one sort of motivation to do what we do. So let's say two parents, they have one baby that has, for example, cystic fibrosis, which means they know each of the parents has one copy of, like one bad copy of the gene for cystic fibrosis. And so they have a 25% chance of having another baby with that. And so that's a perfectly valid reason to do IVF with genetic testing. Eye color is not. And so I've never done a cycle for, to create a baby that has green eyes or something like that. With regards to gender selection, so oftentimes we use guidelines from the American Society of Reproductive Medicine because they have a whole ethics committee that issues statements on a regular basis. And with that, I think it's up to the practice whether they feel like they should provide that. You can make a bigger argument that there are so many women and couples that need treatment and they can only have a baby full stop with IVF. It's maybe not really the best allocation of resources to do this treatment for couples just because they have 3 girls and they want a boy or something like that. But that's a bigger sort of societal question. Our practice, and most places I've worked at in the United States, choose that they are willing to provide gender selection as a reason for treatment. But on a day-to-day basis, it comes up more commonly when a couple has to have IVF for a different reason, like they have to go through IVF because of an infertility, like let's say low sperm count or blocked tubes or something like that. And then if they do the genetic testing to make sure the baby has a normal number of chromosomes, then as a side effect, I also give them the option to say, if they have equivalent quality embryos, I tell them, would you rather have a girl or a boy? And we feel like that's okay.
If a baby was born with IVF, does it stay in the medical record?
That's a good question. I mean, I think that yes. I mean, it's in the obstetric record, and in the pediatric record. Yeah, I mean, I think that's still part of it. I mean, it's something that usually maybe as part of a pediatric visit, the pediatrician would ask about that and have the records, and like as the baby gets care, yeah, that might be in there, but I don't think that's sort of detrimental in any way to that baby or to that child.
Mm-hmm. When I was getting ready for this interview, I read an article about written by a girl who was born with IVF, and her mom actually used the egg donor, and it was her sister. Mm-hmm. And that was kept as a secret for her when she was growing up. Just your opinion on that. Do you think it should be kept as a secret, or it's the world we live in, and thank science that...
So that sort of goes more towards the psychological aspects, and so I'm not like a super great expert on that, but from the lectures that I've heard about this topic, nowadays I think the recommendation is to address this sooner rather than later, both with sperm donors and with egg donors with the child, because at the end of the day, the mother, and this is what I tell couples, like for example, I sometimes have gay couples or lesbian couples who come to us and, with a desire to have a child. I also have sometimes single men who want to have a baby, and they get an egg donor and a surrogate. And so families are created in many different ways in the year 2021. And, like the TV series Modern Family is a good example. Like you see different families, with completely different dynamics and things. But at the end of the day, the people who are the parents are, in my mind, the people who change the diapers of the child. That's one thing. And I do tell patients that I think that, like, when you look at nature versus nurture, and the genetic aspect versus the environmental, I think the environmental is sometimes underestimated. And so, like, I think if you, for example, at age 5, 6, 7, tell your child, look, mommy and daddy, or mommy and mommy, or daddy and daddy had to have a little bit of treatment to have you, and it involved some cells called eggs or sperm, then I think that's much better than somebody finding out at age 21 and maybe even involuntarily finding out that their genetic material is different from who they thought their parents are. So my advice, but this is not like sort of from a certified psychological perspective, would be to be upfront about it and address it early, because I don't think it's detrimental. It was found that the number one predictor for the healthy development of a child is a loving environment and not who the genetic material is from.
Mm-hmm. I see. Thank you. Where do you see the industry, based on your opinion, in 20 years?
Well, I think that there'll be more and more infertility treatment, because this trend that people wait longer to have babies is continuing. Then also the genetic aspects that we talked about, this whole designer baby. I mean, I don't think that it'll go out of control with regards to, I want the quarterback football player who has the quarterback football gene, or I want somebody who's very good with arts or something. I don't think we'll go that far, but I think there'll be more genetic testing so that people will find out more about genetic predisposition. So maybe people will do IVF more for those indications. So I think there will be more infertility treatment. The other thing, that this is a theory that I heard a professor from Australia present at a conference, is that maybe infertility treatment breeds infertility. So, like, from an evolutionary perspective, if a couple has the husband has bad sperm, 200 years ago they wouldn't have had a baby. Mm-hmm. Now they have a baby with the few sperm that husband has, and so maybe that will sort of, in the very long run, propagate more genes that then the offspring will have more infertility, because more fertile couples pass on their genes, and that in and of itself will always make sure that we always have a job, because there's more infertility being created. Now that's the theory, but I do think that our field will grow and grow and grow, and that it will become more common, and I hope that it will be covered by insurance.
Yeah, that was Dr. Alex Quaas. Thank you so much.
Thank you.
For the
Thank you for having
conversation.
Me. Yeah, wonderful. Thank
Good
you.
luck, and a lot of healthy babies, right?
Thank you. Thank you. I appreciate you talking to me.
Thank you.